Welcome to this Ask the Expert activity. Let me introduce myself. I'm Dave Singh. I'm a professor of clinical pharmacology and respiratory medicine at the University of Manchester in the United Kingdom. So today, I'll try to answer your most common questions regarding interleukin-33, IL-33, and its implications for the treatment of chronic lower respiratory disease and severe viral infection. Do corticosteroids affect or suppress interleukin-33 production? So corticosteroids have some suppressive effect on the production of this alarming cytokine. But nevertheless, in the lungs of patients with acute respiratory tract infections, with asthma, with COPD, in more severe disease, interleukin-33 continues to be secreted despite treatment with corticosteroids. And there's a clinical implication for this. We can call it a corticosteroid insensitive or a corticosteroid resistant pathway. That means that despite corticosteroid treatment, interleukin-33 production continues, and they can promote inflammatory cascades that effectively bypass corticosteroids and then need further intervention. The next question: is interleukin-33 more involved in type 1 or type 2 responses? So there's various pieces of data that show IL-33 promotes type 1 responses. Other pieces of data clearly show that IL-33 promotes type 2 responses. So it's a pan-inflammatory, pan-pro-inflammatory alarmin. It also upregulates type 17, interleukin-17 pathways. So it's really difficult to say whether it's more skewed towards promotion of type 2 or type 1 or type 17. It seems to be an alarmin that has a broad pro-inflammatory effect. And I think that has implications for therapeutics that block interleukin-33 and in terms of patient selection for who might be a responder. The current thinking really is that blocking interleukin-33 then could have benefits on different types of patients. Patients who have predominantly type 1 disease, patients who might have a more mixed phenotype. And although type 2 disease is often thought of and referred to as type 2, it's probably not just type 2 on its own. So there are probably other inflammatory components, particularly in COPD. So type 2 probably is just one of the components of disease in COPD that's present. And so interfering with an alarming cytokine that has multiple effects could potentially be quite useful. Next question: would inhibiting both TSLP and interleukin-33 be better than inhibiting either one alone in asthma or COPD? So a really hypothetical question, because we don't have data in patients with asthma or COPD to answer this. We go back to the basic science to address this question. So although they're both alarming cytokines, their signaling pathways are different. The receptor for both of these alarmins is different. So for interleukin-33, it's the ST2 receptor. And there is some signaling through the RAGE pathway. And for TSLP, it's the interleukin-7 receptor, which acts as the receptor for both interleukin-7 and TSLP. So these are different receptors which are expressed to different degrees on different cells. They signal them intracellularly through different pathways. So although they're both alarmins, the reason why I went through that detail is to highlight that the way they promote inflammation is subtly different. And TSLP, what we're learning from asthma and COPD studies, is more skewed towards inhibiting type 2 inflammation. So although there is a broad effect, the effect is greater in patients with more type 2 inflammation. So I suspect that if you were to join both of these in terms of a therapeutic molecule, you would get a bigger effect than inhibiting both alone. Why do I say that? I think the effect on type 2 inflammation from blocking both of these alarmins would be bigger than either alone. And then when you move into the non-type 2 space, that's where potentially blocking interleukin-33 would be beneficial. The unknown question always is that when you move into patients, how big the effect would be. We could speculate, but you'll never know until a clinical trial is actually done. Next question. Can disease activity be suppressed with anti-interleukin-33 agents? So is there disease-modifying potential with such agents? Probably useful to define disease activity first. It's a phrase that's used in many inflammatory diseases. It describes a component of inflammation that can be suppressed or reversed. And if you don't suppress that component, it will lead to tissue damage and permanent disability. So the concept is to measure disease activity, understand that that is a pathway of inflammation that should be targeted, and by doing that earlier in the course of the disease, you may prevent permanent end organ damage. That's the concept of disease activity. So with interleukin-33, then you have to try and intervene earlier in order to have a disease-modifying potential. And that's the same for all interventions. If you intervene too late, then the end organ damage may be far too large for an intervention then to modify the natural history of the disease. So if you can measure disease activity, and for that we need biomarkers, you can target the interleukin-33 pathway, and if you intervene at an earlier course of disease, both in asthma or COPD, you stand a chance over the long term of modifying the amount of end organ damage, and that's disease modification. Again, yet to be studied in clinical trials, but there's clearly potential for many anti-inflammatory agents, and interleukin-33 is amongst these, that early intervention has disease-modifying potential. So the last question, what have we learned in terms of stratifying patients in clinical trials with treatments targeting interleukin-33? So the concept of stratification really is to identify the people who gain the biggest benefit. And with nearly all medicines in all branches of inflammatory diseases, we find that there are patients who respond really well, patients who may have a small response, and then people who don't demonstrate a positive clinical benefit. And the idea then is to identify those who have a positive response, and those who don't benefit, you identify them earlier, stratify them, and they might receive a different medicine. If you can have a predictive measurement, a predictive biomarker, you might be able to predict beforehand that this will be a responder, this will be a non-responder, and give people the appropriate treatments accordingly. So in the anti-IL-33 trials, there is a signal that the effect of these interventions is bigger in COPD patients who are former smokers. There is some biology that supports that current smoking can decrease the expression of interleukin-33 in the airway. So that's one potential. In terms of biological pathways, this comes back to the earlier question about does interfering with this pathway, interleukin-33, have a greater effect on type 1 or type 2 inflammation? I don't think we understand that yet. There is evidence that the blood eosinophil count goes down when you antagonize interleukin-33. And that's to be expected because what you're probably doing is reducing interleukin-5 production from innate lymphoid cells in the lungs, and interleukin-5 acts to promote eosinophil production from the bone marrow and traffic into the lungs. And that's actually associated in the COPD studies in those type 2 patients with an improvement in lung function. But from the phase 2 studies of these drugs, there doesn't seem to be a relationship between the amount of type 2 inflammation, eosinophil counts, and the effect of the intervention on exacerbations. And so you see this divergence in terms of exacerbations and lung function. Maybe the benefit on lung function is greater in people with type 2 inflammation, but the benefit of exacerbations is more. So that's from phase 2 studies, and we've yet to see how the larger phase 3 studies, their results fully reported, and then we can learn more about the concept that I just said and more broadly about stratifying patients to understand responders and non-responders. Thank you for joining me today. I hope there were some valuable pieces of information there. I hope you found this Ask the Expert session helpful. And if you want more educational resources and links to other CME activities, then there's a website here that you can visit. Thank you for listening.